Tonight, we open our Torah to Parashat Mishpatim, where we find the Israelites at the foot of Mount Sinai. Having just received the Ten Commandments, the Israelites are now poised to receive 53 additional laws to help them shape the moral structures of their emerging society. Amidst these laws, some of which are deeply familiar, like do not oppress the stranger and do not take bribes, we also encounter a set of precepts that, at first blush, seem a bit odd and obscure. We read, "When two or more parties fight, and one of them pushes a pregnant woman, and a miscarriage results, but no other damage ensues, the one responsible shall be fined. But if other damage ensues, the penalty shall be life for life." In other words, when two men are fighting and one inadvertently strikes a pregnant woman, causing a miscarriage, the responsible party must pay a fine. But if other damage ensues, if the man strikes the pregnant woman and kills her, the act is considered a capital offense whose punishment is life for life. Note the difference in penalty here. Monetary versus capital. What does that tell us, and why is it important? First, it's critical to recognize that our Torah is saying there is a distinction between losing an embryo or a fetus and losing a living human being. And that distinction has moral, practical, and legal ramifications. There are two separate punishments here prescribed because the status of the fetus, a potential life, is not equivalent to the status of the pregnant woman, a living, breathing person. Hence, the monetary fine for the miscarriage versus the penalty of life for the killing of the mother. This text from Parashat Mishpatim establishes Judaism's historically humane approach to abortion, an approach that does not criminalize abortion, an approach that teaches abortion is not only permitted but in some cases necessary when the pregnant person's life is in danger, and an approach that centers the health, safety, and well-being of the mother throughout the pregnancy. This moral framework grounds our Jewish voice on abortion justice today. Welcome, dear friends, to Reproductive Rights Shabbat. This evening, in partnership with the National Council of Jewish Women, represented here by Andrea Kopel, Executive Director of NCJW New York, we gather alongside hundreds of organizations across the United States to affirm that reproductive freedom is a Jewish value, and that abortion justice remains a matter of urgent Jewish moral concern. At this critical moment when abortion access is gravely threatened throughout the United States, with 20 states having either banned or severely restricted it, we must recommit ourselves to protecting the abortion access we currently have and to expanding it where it has been severely limited or eliminated. We must name and uphold abortion as essential health care, and in that spirit, we must defend life-affirming and life-saving abortion care for every patient who needs it. And this is where our esteemed guest comes in. Dr. Gillian Dean, Chief Medical Officer of Planned Parenthood of Greater New York, is on the front lines of this fight, providing life-saving reproductive health care for so many in need every single day. In her role with Planned Parenthood, Dr. Dean oversees clinical care in health centers and by telehealth across more than 60% of New York State. She is a nationally recognized leader in the field of complex family planning, author of numerous peer-reviewed publications and online resources, and frequently quoted in print and online media. She is a board-certified obstetrician-gynecologist and fellow of the Society of Family Planning and the American College of Obstetricians and Gynecologists. She received her undergraduate degree from Barnard College, medical degree from Harvard Medical School, and completed her residency in obstetrics and gynecology at the University of California, San Francisco, where she subsequently completed a fellowship in family planning. And she received a Master of Public Health in Health Policy and Management from Columbia University's Mailman School of Public Health. Tonight, in a talk entitled An Ordinary Day, Extraordinary Care, 8 hours in a New York City family planning center, Dr. Dean will take us inside the halls of Planned Parenthood, offering us a window into the complex, compassionate, and critical care delivered there each day. Dr. Dean, thank you so much for being with us. You honor us with your presence. Please join me now in welcoming Dr. Gillian Dean to our pulpit.
Hello, everyone. Shabbat Shalom. I have been an abortion provider for almost 30 years. And I can say with certainty that I have never been so grateful to do this work as I am at this current moment. People often tell me, being an abortion provider must be so hard. It must be so emotionally draining. The truth is, I find it energizing and deeply satisfying. I'm definitely not saying it's always easy. It can be difficult work. But for me, it is an act of life-affirming resistance during this dark and divisive period in our collective history. I get to provide people with essential health care that does and change their lives and save lives every day. I know just how critical abortion access is because I am one of the many, many people who has had an abortion. 1 in 4 women in the United States will have an abortion in their lifetime. I can't imagine what my life would have been like if I hadn't had this option at 18 years old. At my abortion visit, I felt well cared for, and I knew that I was caring for myself. That life-affirming experience is why I became a doctor. I went to medical school to be an abortion provider. My abortion gave me my future, my education, my family, my whole career. I have been paying that forward my whole career. Being an abortion provider, that is my way of practicing Tikkun Olam. I'm going to give you a glimpse into what an ordinary day at Planned Parenthood of Greater New York, I'm going to call it PPGNY for short, what an ordinary day looks like. Like many of you, I spend my work days in meetings, most of them. But on Thursdays and Fridays, I see patients. So I'm going to tell you about an ordinary Thursday at one of PPGNY's 19 health centers, the Diane Max Health Center in Long Island, Queens. I actually wrote this a couple weeks ago during the cold snaps, but I just came from Queens today. That was where I was providing abortions today. When I rounded the corner onto 45th Road and approached the health center, I'm greeted by 2 PPGNY volunteer escorts wearing their signature pink vests and welcoming smiles. When there are protesters, the escorts help shield patients entering and leaving the health center from harassment. And we do get protesters, even on this quiet residential street, people who come here to attempt to shame the patients and staff entering the health center. It's heartless. People coming in for an abortion or a pap smear or an STI test, they're not making a political statement. They are just getting basic health care. But today, there are no protesters. It's freezing cold. They seem to be taking the day off. So today, the volunteers simply provide a much-needed welcome. They are the first face a PPGNY patient sees as they come in for care. So one of them kindly opens the door for me. After being buzzed into the center by the security guard, I pass a waiting room already filling with patients. I'm here to provide abortions. However, there are patients I won't see today. They'll be seen by other clinicians for gender-affirming care, menopause therapy, birth control, cervical cancer screening, a breast exam, vaginal discharge, or for a preoperative visit prior to a vasectomy. We see patients of all genders and almost all ages. So I drop my tea in the break room and head to the recovery room to huddle with the nurses. They tell me that there are 27 patients scheduled, including 6 who are in their second trimester. One patient had a failed medication abortion, and we discussed how that can happen about 1% of the time. Another came once before and left because she was undecided about the abortion. If she returns for her abortion today and still feels conflicted, she will be able to meet again with the social worker to discuss her options. So it's 9 a.m. and patients are ready for us, and we dive into patient care. The first few patients are routine first trimester patients. Most of the patients we see are young, healthy, and early in pregnancy. One of these patients is from Florida. She is 8 weeks pregnant. She flew in last night, stayed at a hotel near LaGuardia, and is flying home in the evening. 3.5 years ago, the summer of 2022, that is when Roe versus Wade, the Supreme Court decision affirming a woman's right to, a constitutional right to abortion, was overturned. Every day that I provide abortions, I see people from out of state forced to travel for basic health care that they should be able to get near home. Because abortion is health care, it's essential health care. This young woman from Florida was lucky. She knew to reach out to an abortion fund, and the people there helped her cover the cost of travel, lodging, and the abortion itself, which is not covered by her Florida state Medicaid. At PPGNY, we don't know how many of our patients come from out of state. We found that many out-of-state patients don't want to provide their home address out of fear. Remember, what they are coming to us for is illegal in their home state. So when we ask for their home address, as healthcare providers do, some of the out-of-state patients will give us their sister's address in Brooklyn where they're staying, or the address of their Airbnb, or even the address of the health center where they're standing at that very moment. Out of respect for our patients' privacy and unique circumstances and recognition of their valid fear, we accept the address they provide and move forward. The Florida patient wants a contraceptive implant. She gets that in the OR while still under anesthesia. A few patients want IUDs, and I place these immediately after their abortions. The nurse in the recovery room gives a depot shot, and I prescribe lots of pills. From pregnant to protected, I like to say. Some patients that day don't want to discuss birth control yet, and that's okay. I let them know when they will be fertile again and recommend condoms and emergency contraception and let them know our doors are always open. One patient is farther along than she expected, so I give her misoprostol, a medication to prepare her cervix for a 13-week D&C. She'll wait in the recovery room until she's ready for the OR. I prescribe misoprostol to a handful of patients in their second trimester, and they also move to the recovery room to wait 90 minutes for their abortions. The charge nurse comes to me with a question about a patient with a bleeding disorder. I screened her history, ordered labs, and decided she can safely have an outpatient abortion with us. The nurses will give her TXA, a medication we added to our formulary a few years ago, and it has been a game changer for reducing the occurrence of post-abortion hemorrhage. The sonographer shows me a concerning ultrasound, a possible pregnancy growing into the C-section scar. I asked the charge nurse to refer the patient for a hospital-based abortion, and that abortion provider she will see also just happens to be a PPGNY per diem session physician who works with us on Saturdays. The importance of these local relationships is a reminder that my health center, PPGNY, is just part of a larger New York abortion ecosystem. One patient has a very early pregnancy, so early we can't see it on the ultrasound. It's great that people can get appointments with us just days after their first positive pregnancy test. And we have evidence-based protocols for managing these very early abortions. I explain to the patient that we need to be sure the abortion is complete and to rule out a tubal pregnancy. I order 2 blood tests, one today and one in 2 days, to see if her hormone level is dropping. And I'm glad that this was a local patient and not the patient from Florida, where any follow-up after an abortion is so much more complicated. Next up is the patient with a failed medication abortion. She is very anxious about having a procedure. We do an ultrasound during the case to assure her the abortion is complete this time, and when it's all over, she sobs with relief. The nurse in the recovery room jumps in to support her. They see the whole range of emotions after abortion, particularly relief. In fact, studies show that the main emotion people feel after an abortion is relief. During each abortion, the nurses are my partners. They assess patients for sedation risk factors and run pertinent positives by me. They administer the sedation I've prescribed and provide emotional support and hand-holding during the procedure. They do intra-op ultrasounds when needed and make sure I have the equipment I need to safely and efficiently do each procedure. There are no emergencies this day, but if there were, the nurses would help me manage them. The staff do emergency drills every quarter to prepare. Before each patient sees me, they've met with a variety of staff. If a patient comes in without insurance, she probably met with a financial counselor who would help her enroll in insurance through the Affordable Care Act. If she needs help with covering the costs of care and is not eligible for New York State Medicaid, the financial counselor will see where she falls on our sliding scale based on her income. You may have heard that the Trump-Vance administration kicked Planned Parenthood out of the Medicaid program. Their idea was to stop patients insured through Medicaid from using their insurance to cover the care they receive at Planned Parenthood. To be clear, before Congress enacted this ban, federal Medicaid dollars never covered the cost of an abortion. In the past, when a patient used New York State Medicaid to pay for their abortion, 100% of the cost was covered by New York State, instead of being divided between the state and the federal government as it is for every other kind of medical service. So what changed last year is that the federal government no longer pays their share of any care delivered at a Planned Parenthood affiliate, including life-saving breast exams, cervical cancer screenings, well-person exams, and STI tests. We are lucky to provide care in New York State, where the state has agreed to cover the entire cost of care with state dollars alone. However, I want to be clear that this still leaves PPGNY and the other affiliates of Planned Parenthood in New York State on shaky ground. There's no guarantee that this will be renewed year over year. Moreover, it's important to note that New York State Medicaid reimbursements for sexual and reproductive health care have been stagnant for a decade, while the cost of providing health care has gone up every year. So today, in 2026, for Medicaid patients, we are paid only about half of what it costs to actually deliver the care, 50%. That is not sustainable, especially as a mission-driven organization that provides care no matter what. Most of our patients are insured through Medicaid. Thinking about these attacks emotionally drains me, and it does so for so many of my colleagues. But on this day, I have to shake it off because I have patients waiting for me in the OR. My next patient asks whether the abortion will impact her ability to get pregnant in the future. I reassure her, no, it will not. This is the second most common question I get after, will this hurt? The patient tells me that she is in school and no longer with her partner, but she wants to be a parent someday. Almost every time I provide abortions, a patient will tell me why they're having one. They aren't ready to be a parent. They want to give their existing children the best possible life. They have health problems. They're struggling financially. I wish they didn't feel the need to explain their decision because every single reason is valid. No one should feel obligated to justify their abortion decision. But I'm grateful to be able to listen to them, validate their experience, and provide this service. More and more, as part of these stories, I'm hearing patients tell me what they went through to get to us, how far they've traveled, what they've risked, what they fear when they return home. And of course, Abortion bans disproportionately harm patients with low income and people of color due to this country's legacy of racism. People face many hurdles to access, like finding childcare and covering the cost of travel and lodging associated with trips of hundreds or even thousands of miles. And not everyone has the wherewithal to connect with an abortion fund, as the Florida patient did earlier this morning. The last patient of the day is not here for an abortion. She has a history of trauma, and pelvic exams are difficult for her. She wants an IUD placed under moderate sedation, which we are proud to offer at our centers. And I had that exact same scenario again today when I was in Queens. So during my lunch break, I dashed to a nearby cafe for a matcha, missing always my favorite cafe near our former Manhattan Health Center, where I provided abortion for 18 years. PPGNY sold the Manhattan building at the end of last year. We did this because the space was not ideal for modern healthcare delivery and, frankly, out of financial necessity. We plan to open a new site in Manhattan someday. In the meantime, we have consolidated New York City services into our Brooklyn, Bronx, and Queens health centers. These are the boroughs where most of our patients live, and it is a joy to bring more providers and services into our beautiful refurbished health centers in these communities. Queens, where I'm working to stay, is the world's borough. It is the most ethnically and linguistically diverse urban area on the planet. I am on the phone throughout the day with interpreters speaking Bengali, Cantonese, Creole, Spanish. This diversity is what makes New York City so unique and so rich. Over a third of New York's population is made of immigrants, as those of us in this room well know from our own family histories. At the end of the day, I complete my notes while the last patients complete recovery. I've cared for, well, today was 21, but then it was 20, people seeking abortion and contraceptive services today. When my last patient leaves, I grab my travel mug from the break room and call out my goodbyes to the team. I'm in a good mood. I spent the day working with colleagues who are committed to the patients, to the community, and to each other. Staff who truly embody PPGNY's motto, care no matter what. 13 states have banned abortion, and 6 states have banned abortion after 6 weeks. 1 in 3 US women lives in one of those states. These cruel bans create chaos, confusion, and devastation nationwide. So many people feel helpless right now. I know my personal day-to-day work isn't going to solve this massive national crisis, but it feels good to be able to go into work every day in a health system that provides people with high quality sexual and reproductive health and abortion care, no matter where they live. I always knew that abortion access and reproductive freedom were core values to me, an important part of my identity and my life. And I always knew that my Judaism was, as well, a fundamental part of me. I learned in college that these two parts of me are actually linked. Jewish texts and teachings support reproductive freedom, as the rabbi was just saying. Judaism recognizes the mother's life and health, including mental health, as paramount and characterizes the fetus as a part of her body. Judaism permits abortion, and in some circumstances, even requires it. Reproductive freedom is a Jewish value. And if reproductive freedom is a Jewish value, that means abortion bans are against our religion. I'm honored to be here with all of you to celebrate Reproductive Shabbat. Together as Jews, we can change the narrative around religion, faith, and abortion. Thank you, and Shabbat Shalom.